Hey everybody, it's Dr. Mackey with
Dr. Sloane.
Right on. We are here with your November 1st updates. Good news, bad news. What's the good news?
Got lots of new exciting stuff. We actually are adding a med to our formulary. It's a phenomenal multi-tool, and we're excited to tell you all about it.
And the bad news is you have to listen to us for the next hour, so you're welcome.
Terrible news.
I know.
Terrible.
All right, so why don't we start? Actually, there's more good news, right? We're not going to talk about all the policies that were reviewed. So there's no changes, so we're not going to really go into a lot of detail about them. Matter of fact, we're going to go into no detail about them.
My favorite.
I know.
My absolute
no
favorite.
Details. 2033 determination of death. You already know about that policy. 2060 hospital services. 2085 DNR. 2305 EMS patient care report completion and distribution. 4400 paramedic accreditation of practice. What others, Brian?
We've got 8002 diabetic emergencies, 8004 suspected narcotic overdose, 9001 pediatric airway obstruction, and 9002 pediatric allergic reaction. There is another one, which is pediatric airway management, that didn't change, but we thought it was important enough to do some review as a part of this video.
Then we have another one that didn't change. We're going to save that till the very end, though.
Yes.
So we have a special surprise for you, so stick around. You know, we're going to kick this whole thing off with that drug you were talking about. Mm-hmm. If you've been in EMS long enough, you have heard of this drug before.
Absolutely. We like tools that can be used across multiple different realms. And so this tool is phenomenal. And that tool, the medication is magnesium, and we're bringing it into our scope of practice. It's got a ton of different uses. It's an incredible medication. So the first major use for magnesium, and I think the one that is most critical, is for Torsades points. So polymorphic ventricular tachycardia, cardiac arrest with that twisting EKG that just isn't quite VFib, isn't quite VTach. These patients frequently are resistant to epinephrine, resistant to amiodarone, resistant to shocking. Nothing really works. They need their cardiac membrane stabilized, and the magnesium is going to come in and it's going to fix it. And I can tell you, in another county where I provide some medical direction, we had a case of Torsades, and the patient was shocked, I think, probably at least 10 times. And then they finally got magnesium, and it terminated their Torsades. It was absolutely life-saving, and that patient is completely neurologically intact and normal. So magnesium for asthma and COPD is an incredible tool that decreases hospital length of stay, improves patient symptoms. It's just phenomenal.
Wow.
And then our last big use of this multi-tool is, I think, one of the most important, right? If you're going to just think of one use for this tool, it is an absolutely life-saving tool for pregnant people having seizures, having eclampsia. Magnesium is what's going to terminate their seizures, and they might have seizures that are completely resistant to benzodiazepines, to any of our other therapies, and they're not going to stop seizing until they get magnesium.
What if the person is pregnant but they're only 7 weeks along? Would you call that eclampsia?
No.
Okay.
No, there's a firm cutoff, and we'll talk about it a little bit more in the policy, but a firm cutoff of 20 weeks where we really would consider it eclampsia. However, can I ask you a question?
Absolutely.
What about the pregnant person who's recently had a baby and is having seizures, like 2 weeks ago?
You said 2 weeks, because I was going to say, what do you say recently, right? So recently a year, not eclampsia.
Not eclampsia.
Recently 6 weeks?
Absolutely.
Could be eclampsia. And
it's under-recognized and underappreciated. These postpartum people have a significant risk of having, seizures and eclampsia 6 weeks after they deliver. So it's something to think about that not all of us think about on a routine basis.
Magnesium.
So let's talk about where it's falling into our protocol, right? So policy 8003 seizures is where we're going to put this in. It's not in childbirth, it's in seizures. And that's important because we don't want to be giving this med to someone that we're like, oh, maybe they had a seizure. Maybe it's eclampsia. No, you're going to know it's eclampsia if you're treating this, right? We're not going to be kind of casually giving magnesium to someone who might be pregnant because they feel a little shaky.
Yeah, this is not going to be the 25-year-old with a known history of seizures, hasn't recently delivered, is not currently pregnant, and is not taking their Keppra.
Right.
Right, that is not what magnesium is for.
Right. It's super important that we find the right patient population. The reason why that we don't want to just say that this is a med that we can kind of pass out like Zofran is because we give it in a fairly uncomfortable way, which we're going to talk about. And on top of that, there are some risks. There's some toxicity. There's some respiratory depression, really not at the doses that we're giving, but it's certainly a risk. We're going to give 5 grams of intramuscular magnesium in each gluteal area.
Ouch.
Each buttock.
That just hurts to even think about.
That is a lot of volume. Yeah. That's a lot. That's a huge amount of volume going in as an IM injection.
Yeah. It's not the deltoid, it's not the thigh. The reason why the gluteal region is selected is just because it can handle that volume.
Yep. And so if you have an awake patient who says, I think I might have had a seizure, it's not going to go well.
No, it's not.
No,
it's really not.
Right, but if you have a patient who's actively seizing, or one who's, postictal, is altered, probably respiratory distress already, they're not going to mind. You're going to be giving a life-saving medication, especially if they're actively seizing, because you're not going to be able to give it IV if they're actively seizing. Now, we do have an option for IVIO dosage, which is 6 grams in a 250 cc bag of normal saline over 10 minutes. And I would say, if I had an IV already in a patient with eclampsia, that would be my preferred route. Would you agree?
Absolutely, yeah.
But, and I'm sure you guys would agree, when you have a seizing person, frequently we don't have a nice IV, we don't have a nice IO, we don't have everything set up well, so that IM route is probably going to be our go-to.
Absolutely. And so that drip rate also, it's also helpful, I think, that if you're going to have a drip rate on something and it's something that's set in time, you have a set volume of 250 cc's, it's good to do the math ahead of time. And so basically, if you're using a 10 drop per mil set, and you're going to give 250 mils, that's 2,500 milliliters you're going to give over 10 minutes. And so you're going to be giving about 250 drops a minute.
Wow.
That's moving pretty good.
Yeah.
So 60 seconds.
Yeah.
That's 4 drops a second. It is almost giving it rapid.
And if you've got a seizing patient on your hands, it's a little challenging.
It is.
It's a little challenging, even under the best of circumstances.
You bet.
So moving on, we've definitely talked about how it's critical, it's life-saving, super important. Let's talk about how else we can use magnesium in the setting of respiratory distress. So I'm going to kind of hammer down on pediatric respiratory distress because we have a few tools in our toolbox with pediatric respiratory distress outside of just magnesium. Some of them are not new, but I figured it'd be good to review some of these other tools.
Always good to review.
And so, first and foremost, in pediatric respiratory distress, if we're thinking, bronchospasm, what's your go-to treatment?
Albuterol is always the one I go to.
Okay. There's something else we have now, too. Ipratropium.
Oh, is that Atrovent stuff?
It is the Atrovent stuff.
Okay. Albuterol is a sympathomimetic, so it stimulates the sympathetic nervous system. Ipratropium, or Atrovent, is a parasympatholytic, which is almost like saying it the same way, but it shuts down the parasympathetic side of things, which is usually secretions, mucus, things like that. And it has small amounts of bronchodilation capabilities, but that's really the side of albuterol.
So you're telling me we're giving both of these meds to hit the asthma and the bronchospasm on both sides?
On both sides. Shut down the secretions and open up the airways.
Phenomenal, phenomenal. So another great tool. It's not entirely new with this update, but it is generally new to us, and I think something that we all need to talk about and feel a little bit more comfortable using. I use it in the emergency room. I know you use it in the emergency room.
Absolutely.
I think it's a very useful medication. So, you can give to 0.5 of albuterol and 0.5 of Atrovent and mix them together. So I'm sure you guys know how to do that. I won't spend too long talking on it. Now, we get into an area where we can then say, okay, this patient is more than just a mild to moderate asthma or bronchospasm exacerbation. We need to up the ante a little bit. And so we've got a couple of things we can do to up the ante. You know, number one, we've got IM epinephrine.
Right,
Which
in
is
kids specifically, but
yes.
we also do it in adults. But in this one, we're talking about kids.
Yep. And so I love IM epinephrine. I think it works great in your severe bronchospasm patient, you know, children and adults. I'm a little more cautious in an adult who's older with medical issues.
I am for sure. All right. So how much do I give to a kid?
So how much do you give to a kid of the IM epi? You're going to give 0.01 mgs per kg of the 1 to 1,000. So, you know, that epinephrine, phenomenal thing to use, really works spectacularly. And then we've added magnesium. And so magnesium works by relaxing the smooth muscle that's contracted around those airways, helps open things up a lot more, and really can help these kids. Now, is it going to help right off the bat immediately like IM epi would?
Probably not.
Right.
Probably not as well.
So it takes a little while to kick in, but it really does work. And the way I think about magnesium is it's definitely something that I'm reaching for if I'm reaching for epi. Yeah, right? I want to do both of them at the same time. And this is adults and kids. I'm not going to give epi without magnesium.
Right.
Now, I might sometimes give magnesium without epi, especially in the emergency room where I've got a little bit more time and I can, you know, hook them up to a pump, and my threshold to give magnesium is much lower than my threshold to give epinephrine. But if I'm giving epinephrine 100% or putting someone on CPAP, I'm definitely giving magnesium.
Absolutely. So this is, you'll hear this kind of phrase talked about in respiratory distress, but default aggressive. In these patients in severe distress, like it's kitchen sink time, right? It's CPAP, it's putting them on inline albuterol and Atrovent, it's giving them the IM epi, it's starting the magnesium, it's like boom, 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 boom. We're not like giving one and then just kind of waiting to see how things go, and then we're giving another one, we're waiting to see how things go.
Yeah.
When you get someone in severe distress, those 2-word sentences, kind of
head
a little
bobbing.
bit, head bobbing and stuff, it is game on, kitchen sink.
And I really think about this. These are in parallel processes, not in series. I'm not going to start an albuterol, hey, how you doing, bud? If I'm thinking about the fact that I might need to do multiple interventions, I'm doing them simultaneously because they're sick and they need it.
Absolutely.
And so the last thing that we've got in our pediatric respiratory distress pathway is under Croup and Stridor. So your kids with Stridor, upper airway obstruction, not foreign body, right? Now, there might be times in the hospital where we potentially would use this for a foreign body, but overall, not your foreign body choice. This is the Stridorous kid, almost always going to be with Croup. Yeah, and that's nebulized epinephrine. What do you think about nebulized epinephrine?
I like it. I think it's very, very effective, especially in this scenario. And so this is going to be the scenario. Kid had kind of a runny nose, maybe some low-grade fevers, went to bed, woke up, and was super tight. Those of your parents out there have had a kid who've gone through this. My kids have gone through this.
Same.
It's like a seal bark, harsh cough. Stuff, and they look like they're in distress. That's going to be the picture of the kid. So just a mild upper respiratory tract infection that turns into this like horrible loud cough.
And they get that stridor inhale, and that's really when you start to worry about them, right? They can get that seal-like barking cough. I'm not that worried. These kids get a ton of swelling in their upper airway, and they can actually tolerate a lot of swelling.
For sure.
And so they can get this terrible barking cough, but when you start to hear that after they've coughed, you start to get a little bit worried. And these kids can even have that stridor when they're crying, and it's not necessarily a problem, right?
Yeah.
But if they have that stridor at rest, if you've got a kid who's tired and not crying and has stridor, I'm reaching for epi.
I agree, 100%. Okay, so you finished up pediatric respiratory distress. I'll take on adult respiratory distress, so that's okay. So
Perfect.
80-26. Really the only major change here again is magnesium. All right, and we want to emphasize this so many times for you guys, and so it just kind of becomes ingrained that if you're getting to the world of magnesium, we're talking about moderate to severe respiratory distress. We're talking about super sick patients, so default aggressive.
CPAP, right, inline nebs, they're going to be sick. They're going to be sick, and you're going to not look at them and go, oh, maybe some magnesium.
Yeah, exactly.
It's going to be this is going to be a known sick patient.
Kitchen sink. So I always like to review this policy because there's a lot of words. There is a lot of diagrams, and you can easily get lost. But when you kind of break it down, you really are looking at two pathways. So just as a reminder, we don't have a CHF pathway in this county, and I don't think we need one. We have one in respiratory distress. So remember, when you're talking about adult respiratory distress, you're picking two etiologies. You're picking either asthma, COPD, or you're picking CHF. Those are kind of the two pathways that you're going to be going down. So, and both of them are going to have a component of wheezing.
Yeah.
Right. You're in this policy because you have a component of wheezing already. So once you've decided on a path, and the way you pick that path is based upon the patient's history, their presentation, right? If they have tree trunk legs, big JVD, they got a zipper down the middle of their chest, we're talking about CHF.
Yeah, it's usually not subtle. Usually.
No, yeah. If you walk in and they've got an oxygen canister by their side,
8 bottles
a pack
of
of cigarettes, something like that, and they're maybe thin and like that. So we're talking about COPD or asthma. And honestly, at the end of the day, if the patient can talk, they can tell you. Honestly, I ask them, I say, if I have someone who has both COPD and CHF, I sometimes will ask them, what does this feel like to you? Because they've experienced oftentimes both. They can say, oh no, this is my COPD, right? Because remember, they're both going to be wheezing. So you got to kind of pick a pathway here. But the beauty of this is that no matter which pathway you pick, they all start the same.
So they all
wonderful. I know. Wonderful. They all start. So that's the easy part. So 2.5 milligrams of albuterol, 0.5 milligrams of Atrovent, ipratropium, and depending upon how your patient is going to depend upon the path you're gonna administer it. They may need a handheld nebulizer. They may put a nebulizer through a face mask, or you're going to put it in line through CPAP. So if you're in line, you're in the default aggressive pathway, it's kitchen sink time.
Oh, for sure.
Right.
For sure.
So if you're in the mild pathway, you're going to give that, and then you're going to be moving on from there. So if you're in that severe pathway, you've started your non-invasive ventilation, be default aggressive, 0.3 milligrams of IM epinephrine.
So Dr. Mackey, would you give that intramuscular epinephrine if they had a significant heart history?
If they are in severe distress, I know we were all taught in paramedic school, no epi if they have a heart history. We're talking about a decompensating person right in front of us, that the likelihood of a bad outcome is very high.
Right.
And we talked about being default aggressive. So in those patients, I absolutely would.
Can you tell me what that patient would look like? Like, what am I looking at? Are they someone who's like, man, I can't breathe? Or are they someone who's like slumped over because their respiratory stress is so bad, they're starting to get altered? I say it's that person that's beginning to teeter on that. They're unlikely to be able to communicate very effectively. They may have skin signs, right? They may have sweating. They may be, and they're just super tight and really working to breathe, and they just can't get any air in. Your choice in the next few minutes is going to be grabbing an endotracheal tube. Like, that would be the kind of person that I would be seriously considering about getting epinephrine on as soon as I can. Right, because they're going to get stress on their heart from their severe respiratory distress the same way they would from that IM epi. So it's someone you're going to think really hard about, not just knee-jerk give the epi, but really think about it. But yeah, it sounds like that really sick patient's still going to benefit. And
then you also have this new treatment of magnesium, right?
Love it.
So in adults, 2 grams IV or IO. This is not what we talked about in the pregnant patients, right? We're not drilling their butts with a bunch of magnesium.
No, because these are awake patients who are going to still be kind of mad at you even though they can't breathe. Not seizing.
I can just imagine how you're going to get this patient on CPAP to kind of open a cheek up to you so you can give them. It's not going to happen, man.
No. Although I can imagine the first phone call one of us might get about it. Very fair.
So anyway, so the magnesium, 2 grams IV/IO, and this is given again in a 250 cc bag, as we talked about earlier. This is a fairly fast drip rate. You know, you're going to need to get 2,500 drops in 10 minutes. That's a pretty quick rate. And so it's not opening it up wide, but it's pretty close to being wide open. So, all right. So that covers that side of the respiratory distress. What if you're on the other side of the equation? So if we are over on the other side, we're thinking that this is more CHF. Remember, nitroglycerin is in the milder form, just 1 tablet underneath or a spray underneath the tongue. If you're in the moderate to severe, this is a person you may be putting on non-invasive ventilation. You're going to get to that paste, and you're going to give incremental doses depending upon how severe they are in their blood pressure. And so that's really on that side of the train. We're not giving those folks epinephrine. We're not giving them magnesium.
Definitely not epinephrine.
Yeah,
definitely not epinephrine. Or magnesium.
Or magnesium. So I think the magnesium won't hurt them as bad as the epinephrine, but let's not do either of them.
I've talked to a lot of medics who are like, wow, we keep giving the sublingual, or we keep giving the pace. Like, is there a limit to where it becomes, ineffective? Is it run out of its use? And the answer is no. This is a great medication, and we'll put them on a nitroglycerin drip for a while on the BiPAP, and it really works wonders.
It does. Remember, the mechanism for nitroglycerin does have some vasodilation properties, which we all learned about in paramedic school. But remember, its major property is also preload reduction. So you're trying to offload the heart of all of that stress that's coming in, and it's trying to push out, and it can't, so all this fluid is filling up in the lungs. When you offload that pressure off the right side of the heart, and you decrease that preload, the lungs can start to dry out, the respiratory compliance gets better, the heart gets a little bit more rest. So
absolutely.
I'll get off my nitroglycerin train because it's a big one.
So let's say we have a patient in Torsades, we give our magnesium, we get return of spontaneous circulation. What do we start to do at that point?
That's the most important part, is that there's going to be 2-minute cycles here, right? We've just gone through some 2-minute cycles. Now we're going to go through some more cycles about what to do after you get ROSC. And there is a major thought shift in post-resuscitation care. And that thought shift goes around managing the airway, managing the patient's blood pressure, and being ready for the patient to crash again. This is a major adrenergic fight that their body's been in, and their adrenal glands have dumped every ounce of adrenaline into their system. We have added more adrenaline on top of that, and their body is just trying to recover from the storm that it just went through.
Right.
So when you do successfully get ROSC, the very first thing, and none of this has really changed, but we just want to re-emphasize it. The first thing we want to do is really focus on that airway. What you want to do is you want to be looking at your respiratory rate, and you want to be looking at your end-tidal CO2. All right, so in those two things, you want to just manage the parameters, try to getting your end-tidal CO2 to 35 to 45. Remember, in ROSC, it could spike pretty high.
And you could see 50 to 60 And it's going to normalize after a few minutes of ventilation.
Exactly. So be disciplined at staying at 10 breaths per minute. Be disciplined at that.
And it's important because we really hurt a lot of people with overventilating. And I think EMS providers as a whole are much better than we are at the hospital. But I know whenever I have a post-ROSC patient, Medic 76 brings me a post-ROSC patient that they have excellently managed. And I come in and I have an RT who's bagging them like this and completely distending their chest. What is that going to do when we overventilate someone? It's going to increase their intrathoracic pressure so much that they're actually not getting any blood flow back to their heart. They become more hypotensive. Well, that nice ROSC patient's coded again.
Yeah. And remember, this is not an ALS skill either. It's really important, right? Our EMT partners are really good at ventilation.
Phenomenal.
You can hand this off to your EMT partner, paramedics, and say, I want you to focus on two things. Watch that number, try to keep between 35 and 45, and I want you to focus on 10 breaths per minute. That's it. Because the next thing you need to be doing right away. Getting your push dose pressor ready. You need to be ready to support that blood pressure and that pulse when it starts to tank, because when you start to see the blood pressure go from 110 to 70 to 40, and then you start thinking about your push dose pressor, it's too late.
I tell my guys at Folsom that I want to have a bandolier made for push dose epi because I love it so much, right? I love push dose epi. If I get a radio ring down that I'm getting a super sick patient, especially if they're post-ROSC, the first thing I set up is my end tidal. Second thing I set up is push dose epi. I love push dose epi. It can completely turn that peri-arrest post-ROSC patient who's gonna code again into a rock solid stable patient.
Exactly. And I get a lot of questions from the field about this. Like, the range is 0.5 to 2 milliliters of this 1 to 100,000 mix. And they go, how much do I give? Do I give 0.5? Do I give 1? Do I see how it goes? Ladies and gentlemen, listen closely. Give 2 and be done with it. Just give 2 and be done with it. 2 and wait for another few minutes if they need another one. 2 more, 2 more, 2 more. Like, literally, don't game around with the 0.5, the 1s, the 1.25s, the 1.5s, kind of tincturing it. 2.
If they need the push dose epi, they're going to need it. And you're probably going to need multiple doses.
Yeah. So we've started out, we got our ROSC, we got someone on the airway, they're managing their ventilatory rate, we're looking at the end tidal CO2, we're getting our push dose pressor ready, we're managing the hypotension. But what haven't we done yet? We haven't gotten our
EKG.
12 lead. And that's important.
We should get that the moment we get ROSC, right? As soon as we get ROSC.
Oh. Absolutely not.
Oh.
No, and there is a fairly good study out there about this too, about at what point do you cross a line when you get your 12 lead in a post-ROSC patient where it's no longer a false stemming.
And so that makes sense, right? Because that heart has been under so much stress and gotten so much epinephrine and is now just seeing oxygen for the first time that it's been arresting, that it's probably not going to be giving adequate EKG tracings, right? It's not going to be what the true tracing is, because you're looking at basically a heart that's been dead and now brought back to life. Don't look at me for the best advice when I wake up from a nap. Give me 5 minutes. Give me a cup of coffee first. Same thing with this heart, right? Give it a chance to have its cup of coffee before you start talking to it.
It's the first time in my entire career I've heard a nap compared to cardiac arrest. That's fantastic. I'll never forget that.
And neither will they now.
So your 12 lead, what's your timing on your 12 lead? It's at 7 minutes. And so wait that 7 minutes to get your 12 lead. And then you can start thinking about moving the patient. You guys, I know in your department, in my department, I know at Metro and at CSD and with our private providers, there has been a fairly significant pushback. Like, we've got ROSC and you're almost like you're sitting there, you're waiting. It's like, if I get to the hospital fast enough with a beating heart, then I don't have to deal with the after effects. But that rush to move the patient once you have ROSC undoes everything you've spent your time doing over the last 15 to 20 minutes.
It's a really unnatural thing to say, we've saved this person, we've worked really hard, we have pulled them from the brink of death, it's time to go, but I'm just gonna sit here.
Yes, it is literally hurry up and wait. So we rolled out a policy here in adults a while ago called 20 CRW. So if you don't remember what that means, the letters mean cool running water. So now it's part of the pediatric policy as well. And you're right, this isn't typically the person that you pull out of a structure fire because they're going to have respiratory involvement. And they really do need something more than we have in the field. So getting them to a burn center is key. And our burn center here, again, for adults and for kids is UC Davis. But this is going to be for that patient that has less than 30% total body surface area, which if you think about it is a lot.
That is a lot. That's a surprisingly large amount of, yeah.
Yeah, that is still a lot. And that includes, people with respiratory burns are not in that, but burns to the neck, to the chest. And if you want to know some statistics, since I kind of geek out about statistics, I know you do too sometimes.
Absolutely.
Like more than 75% of these patients are going to be burned with thermal burn. So this is steam, this is hot water. Then a small percentage are by flame. And almost all of these, 80% of these happen in the home. And so, but the thing that is so important to wrap your brain around with this is that the intervention that you do right there in the person's home or on the side of the street makes a massive difference downstream. So when you experience a burn, that tissue underneath continues to cook. And so the sooner we can start cooling that cooking process, the less the depth is for the burn itself.
So then why don't we just do like a submersion? So if my hands are burned, I could just submerge it in water.
Right. And that's a good question. Or why don't we just wrap it in a cool towel or put a pack of ice on it or something like that? Or even worse, put salve or some burn ointment on it. That's terrible. It's because that area right around the burn rises in temperature very quickly and then stays there. So it's the effect of the running, that R in 20 CRW, the running part is really important. So how do you do that effectively? Like you can do it with a garden hose, you can do it with a shower, putting the patient in a shower.
That's a great one. That's a really good one.
Yeah. So do I need to stay here on scene and do this, or should I transport and just do it at the hospital? I will tell you folks, and you will support me on this.
Absolutely.
Hospitals in general are not set up to do this.
No.
Our hazmat showers are set at about 85 degrees. Next time you have a burn, try putting your arm or whatever you burn under 85 degrees of water, and you will understand pain at a new level.
Oh yeah.
And so I want you to begin to think of this phrase for adults and for kids: cool the burn, warm the patient. So you can wrap the patient in blankets or whatever's not burned, and keep them warm. What about hypothermia? That question gets asked a lot. There's not been any really good documented cases of hypothermia, even with larger burns. I'll tell you, in Australia, there's no limit to 30%. They go up to 60, 70% burns.
Wow.
And they don't have issues with hypothermia. What about infection? We don't need to worry about that either, because all of these patients are going to end up getting debrided, and some of them may be put on antibiotics, especially going to a burn center. So we don't need to worry about hypothermia or infection, but keeping the patient warm is really, really important. Yeah. And you know what you do with the burn after you cool it?
What's that?
This will really blow your mind. We carry all these really expensive, like burn dressings, non-stick dressings.
Oh yeah, they're marked. They're great. They're super cool. They're in shapes.
$20 a pack.
Yeah.
Saran wrap. Literally Saran wrap. I know. So, and I'm not talking about wrapping it circumferentially. Let's say like my arm were burned. So it'd be taking 2 pieces of Saran wrap, one down this side, one down that side, crunch it together in the middle. Here's the beauty of that. It doesn't have any or carry any bacteria. You can see through it.
Oh, I like that.
It'll expand, and it's easy to remove. It doesn't stick to the wound. So think about this in kids. One quick review. 30% total body surface area burn or less, no respiratory involvement. No need to urgently get to a burn center, like you don't have any airway involvement. stay there. Our dispatch center now has a policy in place that will instruct the parents, or if in this case it's kids, so the parents usually are caregivers, to start the 20 CRW even before you get there. So one of the first questions I would ask if I walk through the door and I see them cooling the kid in a sink or in a shower, how long have you been doing this? 5 minutes. Okay, great. I have 15 minutes more. Stay there. I'm going to start a clock. 20 minutes of cool running water within the first 3 hours of the burn injury.
Pediatric airway management, right? There's not changes here, but it's one that I think is super important to talk about, right? I want to be good at doing things that I'm not good at. You know, as a quick review, what are our blocks here? Number one, we've got certain very distinct blocks of when we're managing an airway with a supraglottic airway or a BLS airway versus when we do an endotracheal intubation. And so that firm cutoff is 8 years old and orange, right? If they're below 8, we're not intubating. If they're above 8, we can intubate. Do you know where that cutoff came from, or the whole premise of not intubating children came from?
Tell me.
So interestingly, there was a study that came out of Los Angeles. And so I'd like to talk about it. And I think this is, and the reason I want to talk about this is frequently something that my paramedic students and my young medics ask me about, saying, hey, why don't we have peds intubation back? What happened to peds intubation? So I like to talk about the background here because it's actually very interesting in context of how we make all of our decisions. But that study showed that the kids did better if they weren't intubated. Now, the interesting part, does that study in Los Angeles equate to how we practice?
Not today.
Not today. But that's all the data, that's the best data we have at the moment.
At the moment.
At the moment.
Right.
Exactly.
There is a study going on.
There is.
Which a fire department near you is participating in.
There is.
Called PDPART. So PDPART is a study that is looking at head-to-head comparison of pediatric airway management of a bag valve mask and a supraglottic airway. And the winner of that, this is multiple departments throughout the U.S. The winner of that, if you call it a winner, BVM versus supraglottic, will then be compared head-to-head against intubation. Phenomenal. And what the interesting thing about this study is we're following these kids through to discharge. So it actually is following them beyond just the emergency department all the way through to discharge and outcomes.
So this is such a perfect example of why it's so important that as EMS clinicians, we are focused on collecting appropriate data, on following evidence-based guidelines, because removing pediatric intubation was based off of the best possible evidence at the time.
Yeah, and documentation is a huge part of that.
Huge part of it.
Huge part of that.
Because if we're going back looking at this, we're looking at your documentation.
Yeah, that's the only, we're not there. We don't have video cameras. The only thing we have to tell your story is your documentation.
And so the policies we have now are based off of that one study, which was done as a randomized controlled trial, which at that time, and still currently, is the gold standard, the best evidence we have. We're working on changing that, but to get there, we need investment, we need engagement, we need good documentation, we need thoughtful medics doing a good job to show, yes, we can do this, we can do this better. And on top of that, it's very interesting to think about that our protocols here in Sacramento depend on studies that were done elsewhere.
Yeah.
So it's a very interesting thing, there's so much still going on in EMS that's evolving, that I wanted to bring this up to talk about for you guys where these decisions are coming from. It's not just us sitting in a room with a couple of scotches going, you know what, it'll be cool, let's take intubation away from them. You know, it really comes down to we have to measure the evidence we've got. So anyways, enough of that. Important things for pediatric airway management, and the one thing I really want to harp on is focus on your positioning.
Amen to that.
A kid is not an adult. You can tilt an adult's neck back and get a pretty decent airway even with a BVM. But if you've got a young child, especially a young child like my kids with ginormous heads, and you just tilt their head back on the same level as their back, they're going to lose their airway. You know, and so getting really good position, getting the kid into the sniffing position with their bottom of their ear lined up with their sternal notch so their head is forward and tilted up makes all the difference. And we'll put an image up to show you really, if you've got a kid who's not breathing that you're using a BVM on, don't hesitate to put a shoulder roll and a head bump to help you manage that airway. The majority of these kids are having their medical emergency that they're having because they lost their airway and they didn't oxygenate.
have one more.
We do.
I think this policy is so important that we should get on a plane
Oh, I love that.
and we should fly somewhere and talk to someone about it.
Where are we going?
I think we should go to EMS World.
Let's do it.
All right. So we're going to take a pause here, you guys. We're going to get on a plane, literally.
Yep.
And we're going to fly to Indianapolis, and we are going to interview the consummate expert. Well, I'm not going to interview you. You're going to interview him. Interview the consummate expert on patient-initiated refusal.
Thank you for joining us here at EMS Expo 2026. We're in the absolutely stunningly beautiful Indianapolis, Indiana.
Yeah, not bad. Indianapolis.
I mean,
who knew?
I prefer Sacramento.
I prefer, the Bay Area. But here we are. So.
Anyways, thank you for joining us. Again, I'm Bryan Sloane. I'm the medical director for Folsom Fire. Joining me today is our special guest, John Ray.
And good morning, everybody. I'm John Ray Howson. I'm an attorney, registered nurse, and paramedic. Been in EMS in some form or another for a little over 20 years now. Over the past better part of 6 years or so, really specializing in EMS law and working with ambulance companies and EMS agencies and systems to hopefully ensure that providers can do better and safer patient care that's still maximally aggressive.
We wanted to talk a little bit today about patient-initiated refusals. And so even though this wasn't one of our protocols to be updated, it's a really important one to talk about. I think it's one that gives myself and the other medical directors the biggest heartburn. And so, John Ray, what do you think about patient-initiated refusals? Is this something we need to pay attention to, or is this kind of like a minor point in the grand scheme of EMS protocols and policies?
Before we do that, I just need to give you a quick disclaimer that while I'm an attorney, this is not legal advice. You should please consult with a licensed attorney representing your EMS agency and not make any legal reliance on the advice or comments that are given here today.
The question I have for you, John Ray, is, when we're going about our day-to-day operations, when our providers are going about their day-to-day operations, these patient-initiated refusals, or AMAs, or Code 4s, are they a point of significant risk and concern? Is this something that gives you, as an attorney, heartburn?
Absolutely. I think anytime we're doing a refusal, especially a refusal where someone's saying that they don't want to go to the hospital, there's risk there, right? And there's risk there in some respects that's twofold. There's risk one, if that patient later has a bad outcome, did they really understand what they were doing when they signed that refusal? Did you as a provider do everything that you reasonably should have done that another similar provider with your background, training, and experiences would have done to try and appropriately convince them to go to the hospital? But then there's also risk if you say, well, I know that you're refusing, but the hospital says you got to go, so let me just strap you on a gurney and take you to the hospital. Well, now there's risk. Now there's risk with that as well. So these refusals are, I think, shroud in risk.
Okay, but I had the patient sign the AMA form, so I'm good, right? If I have them sign the form, they signed it, we're good. I'm absolved of any liability there, correct?
Did they know what they were signing? Did they understand what they were signing? Did you explain it to them?
So you're telling me I need to do a better job, if I'm out in the field as a provider, documenting really a lot more of that refusal process, of the capacity, of the risks that I discussed with the patient, of their alternative plans. All of those things should be in my note, right?
Well, I think you're getting there, yes. Most importantly, when I'm doing a refusal, or when I see refusals done, especially when I've seen refusals done poorly, there are a couple things in common. And you hit on some of that. First, we generally don't explain risk well to patients. Right? What are the risks? And the common line that I know we've talked about is up to and including death. Okay, what does that mean? Tell me the specific risk that we're concerned about, and do so in layman's terms. I'm worried that you could have a severe head injury with bleeding into your brain. Right? I'm worried that you could develop sepsis and end up in shock. So I like to be specific with the risk. That's one. The second big thing that is super important, you have to understand why the patient wants to refuse care.
Yes, that's a core point. And should we be documenting why they want to refuse care?
Of course. I think not only documenting why they want to refuse care, but if someone says, I don't want to go to the hospital because the wait time at hospital X is going to be 3 hours, okay, then what did I do to attempt to alleviate that concern? So whatever the patient says is their reason for a refusal, especially if I'm really genuinely concerned about that patient, I should be taking efforts to address that specific stated risk and then documenting that. You don't want me to start an IV? Oh, okay, great. Maybe I defer my IV start.
And then so one of the things that I see a lot when I get a patient who comes to the hospital, and it happens, I can tell you guys at least 2 or 3 times a shift. I have a patient who comes in through the front door, not via ambulance, who's like, yeah, I called the paramedics and they came out and they said that I was fine to take myself to the hospital. They said that my EKG was normal, so I could just follow up with my primary care doctor. Now, if we're in a situation where you as a provider are encouraging a patient to take themselves to the hospital, could that put you in a significant amount of risk?
I think that's highly problematic, and any refusal needs to be tailored to that specific patient's situation and that specific patient condition. You not wanting to transport someone to the hospital and encouraging them to go, quote unquote, against your advice isn't really an effective form of an AMA, because what's your advice? Well, your advice is, hey, if you don't want to go to the hospital, that's fine, that's okay. You don't have to go. There may be a long wait time. I'm not sure you really want to go. That's not an AMA, that's a provider. That's starting to sound like a provider-initiated refusal. And if there is a bad outcome, and those facts come out, and those facts will come out, that's not going to look like the patient really appreciated the risk of that refusal, which is an essential part of any refusal.
Right.
You have to understand the risk.
So there's another type of issue that I think we should discuss, and that's the delineation of a patient versus a person. When do we actually develop a relationship with a patient that requires a PCR, and how valuable is a PCR in that case where, let's say you get a 911 call for an unresponsive person, the first arriving unit shows up, walks over, says hi to the person pops right, oh no, I'm cool, I'm fine, and walks away. I would say that some providers might say, hey, that's not a patient, they didn't need an assessment, I didn't do anything. And I think there's also the train of thought that is, hey, even walking up and saying hello constitutes an assessment in which a PCR would be beneficial to protect you from risk. What's your thoughts?
So here's the way that I'll frame this.
Okay.
If something goes sideways with that individual, person, patient, whatever you want to call them, they have a bad outcome, and it comes out that you were there as the fire department assessing them and treating them, or even that you were just on scene, that's going to present some challenges, right? And if a plaintiff's lawyer gets a hold of that case and goes, oh my gosh, the fire department was there, they came out, they assessed my client, and they did nothing. They came out and they did nothing. If you have no ability to document what you saw and what you did, even if it was minor, you're going to be in a much worse spot than if you at least have something that says, we showed up, we had a conversation, person insisted that they didn't want to go to the hospital, they said they were fine, talked to them about really being seen and evaluated, they said, no, it's okay, I don't want to be seen, I don't even want you to treat me, I'm all good. and I can document that patient was answering all questions appropriately, appeared to be alert and oriented, walking with a good steady gait, skin's pink, warm, and dry, does not appear to be in any obvious distress. I can put all of that on about a 5 or 6 line narrative, and even if it's just that, you're still going to be in a much better spot than just going, yep, no patient contact. Now, I think what's even worse, and certainly what I've seen cases on, I've seen cases where crews have actually come out, taken vitals, done a full assessment, and then gone, it's okay, no patient contact, you don't want to go, that's fine. I'm sorry, if you touch somebody, you put a monitor on them, I think you have unequivocally walked into that segment of patient contact. Even you start to have a conversation and start asking people questions about their condition, you've created some degree of patient contact.
I would agree, and I think, when I've gone through, in my current role and in past roles, and I've ever had a provider have a problem that resulted in a disciplinary action or a loss of credential or anything like that, it's been almost exclusively as a result of a no patient contact or as a refusal that's went south. Would you agree that's probably one of the highest points of liability for our providers is these refusals?
I think in 911 systems it's certainly up there. I don't know if independently it's the highest risk, but it's certainly one of the highest risk. We're talking about telling someone potentially who has either called 911 for themselves or had 911 called for them, we think you need to go to the hospital, you're telling us no. Now, if something happens, maybe it's the patient who goes, wow, I really wish I understood what all the risks were of this were, and had I known that they were concerned that I was going to have a severe head injury, of course I would have gone to the hospital. Had I known X, of course I would have agreed to care and treatment. Or even worse, well, I didn't think they were going to take me to the hospital because they said, well, because they told me I didn't have to go. They told me, we think you're probably fine, but it's always the safest thing to be checked out. And they did this sort of refusal in a way that was what I call the soft refusals of, like, well, we can take you if you really want to go. I know you probably don't want to go, but it's going to be really busy. It's going to be long. Look, you're probably fine. Everything I'm seeing here on my EKG looks great. And what you're doing is you're framing the situation and you're framing that case in a way in which indirectly says to the patient, you're fine, you don't need to go. This really isn't my medical advice, but here, sign here, just as a formality. Was what I call the soft refusals of, like, well, we can take you if you really want to go. I know you probably don't want to go, but it's going to be really busy, it's going to be long. Look, you're probably fine. Everything I'm seeing here on my EKG looks great. And what you're doing is you're framing the situation and you're framing that case in a way in which indirectly says to the patient, you're fine, you don't need to go. This really isn't my medical advice, but here, sign here, just as a formality. And I think that's super dangerous.
I would agree. And to wrap this up, I know it's turned into essentially a Halloween Horror Nights of risk. But to wrap this up, what kind of risks could our providers face, both professionally and personally, if something like this goes wrong?
So you've got risk at all levels. Certainly, this is 2025. Everything is on body camera, especially in California. Can have DA's offices who are not afraid to charge providers for criminal actions that previously may have been handled civilly. Certainly, negligence is a big one. Professional negligence. If you owe someone a duty, you breach that duty by falling below the standard of care. You actually cause harm, you proximately cause harm, and you have damages, there's risk there as well. And then obviously violation of the EMS Act or violation of different LEMSA protocols can all have a direct impact on your license. Risk is everywhere. And nothing that we do in EMS, nothing that we do in medicine is risk-free.
That's true.
But what I always encourage people is you have to be reasonable. Above all else, be reasonable. Ask yourself, what would another EMT, what would another paramedic with my similar background training experience do in this situation? And if you can answer that question and go, yeah, they'd probably do the same thing, then you're being reasonable. And above all else, be reasonable, because that also helps cut off the causal chain for negligence. And then second, be kind. Because it is amazing when people are kind, aside from you just having a better career and you just feeling better about yourself at the end of the day and putting good karma out there, there's a lot of great evidence and a lot of great studies that physicians who are kind get sued way less. So be kind, right? It's good from a legal standpoint as well, because you're never going to be perfect. Things will happen, but if you're reasonable about it and you're kind, you're probably going to be fine.
Well said. So end all takeaway from this, take these refusals a lot more seriously, really think about what you're doing, and then take a second to pause at the end. Am I being kind? Is this the right thing to do? Not only for the patient, but for their family, for the system, and for us.
Understand why the patient wants to refuse care, and take action to document that, and take action to try and alleviate that specific concern.
I like it. Well, thank you for joining us here at EMS Expo. We'll see you around.
Bye, take care.